Thank you for this opportunity again. I'll be speaking on DONFL and SANFL. From here on, I'll refer to them as DONFL and SANFL, otherwise it will take me 15 minutes to finish the talk. So we know that ILM contributes a lot to the retinal strength because it's the main membrane that transmits forces from the vitreous to the retina, and the removal of the ILM causes almost a 50% reduction in the mean strength of the retina. So first, SANFL, it was first described in ERM and macular hole surgeries after ILM peeling. About 30% eyes of 100 eyes had a post-operative swelling of the RNFL. These are seen as hyporeflectant on infrared imaging and on blue autofluorescence, and they correspond to a hyperreflected swelling on the OCT. So this is supposed to be due to direct surgical trauma, where there is an over-enthusiastic attempt at pinching the ILM in order to peel, and there is, because of that, there is a retrograde axoplasm transport which is disrupted, and they lead to these striae that radiate towards the optic nerve. So it is also said to be because of Muller end plate damage, because these end plates are directly attached to the ILM, and it's an acute phase reaction to trauma. So this is one of our cases where ERM peeling was done, and after 10 days you can see these hyporeflectant arcs radiating from the optic disc, and there is, although there is overall reduction in thickness, there is a definite increase in the NFL thickening temporal to the disc. So after 3 weeks, this swelling decreased. You can see the thickness analysis as well, and there seems to be a definite reduction in the SANFL. This is another case where we had done an ERM and ILM peeling. This is one particular hyporeflectant area here. So we can see that there's an actual reduction in the SANFL 3 weeks after surgery, dramatically in the temporal and less so in the nasal. So the nasal side of the macula takes longer to become thinner after SANFL. So SANFL, even in studies, have been described as disappearing in all eyes at 2 to 3 months, and there's no significant effect on visual acuity measured even at 6 months. So next is DONFL. It is described as a moth-eaten appearance, best seen with blue light, and they are seen as dark striae in the RNFL arrangement. So this is also seen after ILM peeling for ERM and macular hole surgeries. These are in fact small spindle-shaped splitting of adjacent nerve fiber bundles, and these are seen as depressions in the macula, and on the onfas they have a typical concentric dark spot appearance known as CMDS, that is concentric macular dark spots. So this is one of my own patients where ILM peeling was done for ERM, and in fact we could see an increase in the CMDS over time. So the hypothesis for the development of DONFL is possibly because the traction exerted during the ILM peeling. Wherever there has been incomplete ILM removal, you will not see DONFL, and where there is removal, and especially where the ILM is thin and the attachment plaques between Muller cells are scarcer, that's where we see this. So it's wrong to actually call it dissociation, because it's not an actual loss of the RNFL, it's more of a cleavage or a separation of the NFL. And we see a definite temporal macular thinning, as you can see in this particular case of us, where at the end of 2 months, there was a preferential temporal thinning. The nasal side is spared probably because there is more tight packing in the papillomacular bundle, which resists traction. This is a very dramatic temporal thinning seen in this case, where the thinning in the temporal area is to the tune of 250 and the nasal area is just 2 microns. So why this sharpest depression is seen in the temporal subfield is because of the shortening of the papillofoveal distance. So since ILM does not have contractile properties, and after ILM peeling there is some amount of RNFL contractility because of the actin and myosin interaction, there is a foveal displacement towards the optic disc which causes a stretching concurrently in the temporal fovea. So there's a shortening of this distance which causes an apparent reduction in the macular volume and thickness. So post ILM peeling, there are some effects which we see on the NFL thickness. In the early period, we see that the superior nasal and inferior areas surrounding the disc become thickened, and this is because of generalized swelling because of the surgery itself. But 6 months later, there is a focal damage and loss of GCC and NFL thickness in the temporal quadrants preferentially. However, this is not associated with either SANFL or DONFL. You can see that there is reduction in the temporal quadrants. So what happens to the ganglion cell layer? Wherever the ILM has been peeled, this corresponds to a diffuse thinning of the GCC, but not necessarily loss of the GCC, because it is said that the Muller cell volume is lost because their cell bodies reside in the ganglion cell layer. So this is just an example of what is definitely not DONFL or CMDS, because we see these NFL corrugations in long-standing ERMs which persist after surgery. So this is not a concentric kind of dark spot. These are because of NFL corrugations on ONFAS. So this is another case where you see I had to really hunt for a cleavage, and this was one, and correspond to a depression in the NFL which was limited to the NFL, and these are actually the NFL striations or the corrugations. So what if there is DONFL or SANFL? So nothing really actually. SANFL has no effect on visual acuity. It disappears in 3 weeks to 3 months, and are they a part of a spectrum? Again, no, because SANFL is a subacute trauma which is seen in early post-op period, and DONFL is a late post-op period finding. And even despite this cleavage, there is no effect on the vision or microperimetry. So, in fact, it can be used as proof of definitive ILM peeling, because only if ILM is peeled do the Muller cell end plates get lost. Thank you.